Right. So we'll may continue the discussion. Probably we'll have some more time. I would like to give a different perspective on the surgical management, where corneal edema doesn't permit just the good view of the angle to the extent that you can do goniotomy scientifically or to your satisfaction. What is the option? Now, a patient presented here with corneal edema bilateral. Simultaneous bilateral surgery was there, we did, but the question comes, what is the best primary surgical treatment? If we see the options available, starting with goniotomy in the year 1938, till date, several surgical techniques came into the literature, and before 1938 there was no surgical treatment, and the ultimate outcome was blindness. Primary combined trabeculotomy is a technique which is probably suitable and probably the most important technique in most of the patients we see in India. I learned the technique from my mentor, Professor N.N. Sood, while I was doing my senior residency with him in 87 to 90. Then I moved to L.V. Prasad Eye Institute, where in last 35 years, I'll present the outcome of the surgery. A very important surgical technique came into the literature, fiber optic microcatheter trabeculotomy, 360-degree circumferential trabeculotomy. And we recently, in the year 2022, described an improved technique for neonatal onset primary congenital glaucoma, where 360-degree trabeculotomy was combined with trabeculectomy. Now, if we go into the literature, only a few percentage of patients do this surgery, combined trabeculotomy, trabeculectomy, we call CTT, because of the obvious reason that in some countries, corneal edema is less, and probably the disease is not very severe. Their goniotomy or external trabeculotomy may be performed. So we'll come to the surgical technique in a composite edited video for 7 minutes. I'll come to it. I'm just saying that this is the deroofing of the Slem's canal, just to show how the Slem's canal looks like in ab externo approach. So I am presenting this video, the outcome of this video. Muralidhar presented this slide. It is a case of infantile onset, I'll say acute hydrops, and you can see how beautifully. Can you improve the sound little bit? You can see the halves dry, and the corneal edema cleared. This child completed about 13 years of follow-up studying. We are looking into the other eye very carefully. There was no glaucoma so far, but long-term follow-up is required. So the question is, any patient of unilateral onset glaucoma, here is the composite picture, how the corneal edema cleared, and we published this material. Here is the child. A few years ago the child came, and you can see at presentation and 10 years post-operative. But look at the corneal endothelium in the afflicted eye, later eye. It is so poor. In course of time, there may be endothelial failure, and patient may require endothelial surgery in the form of DSEK or DMEK. So I am presenting a video. Watch carefully. Sound is included.
मैं प्रमोद पाटिल, महाराष्ट्र जलगांव से।
मैं पूनम प्रमोद पाटिल हूँ। मेरी डिलीवरी प्रीमैच्योर थी। 10-15 मिनट में पता चल गया कि हमारा बच्चा ब्लाइंड है। तो मैं इतना रोई थी कि मैं बोली थी मेरे को बच्चा ही नहीं चाहिए।
मैं डॉक्टर के पास में गया और पैडियाट्रिशियन के पास में। बोलता बच्चे का कंडीशन कैसा है? बोलता बच्चा तो ब्लाइंड है, तेरा बच्चा अभी ऑक्सीजन पर है। मैं रो दिया उसके सामने। मैं बोला भाई, हमारा जिंदगी क्या होता है, तू इसके बारे में नहीं जान सकता है। नासिक में हमको डॉक्टर अनिल मंडल सर का नाम भी और हैदराबाद अस्पताल का नाम भी पता चल गया था।
मेरे को इन्होंने बोला बच्चे का ऑपरेशन हो जाएगा, तो टेंशन ना ले, ऐसा वैसा वो सब बता दिया। तो यहाँ पे बोल रहे थे मेरे को हैदराबाद एलबी प्रसाद में ऑपरेशन बच्चे का हो जाएगा।
The child was born out of non-consanguineous marriage and both the parents were blind because of congenital glaucoma. Simultaneous bilateral primary combined trabeculotomy and trabeculectomy was performed on this baby at the age of 3 weeks when the body weight of the baby was 1200 grams. This is the preoperative appearance of both the eyes, showing megalocornea and corneal edema. What follows now is microsurgery on the right eye. A 1/2 thickness scleral incision is delineated and a partial thickness scleral flap is then dissected towards the limbus. Surgical landmarks and anatomy of the limbal region is carefully identified and a 2 by 2 millimeter trabeculectomy block is outlined without penetrating into the anterior chamber. A central radial incision is then made just behind the outer landmark of scleral spur. The objective of this radial incision is to cut the external wall of the Slem's canal and to avoid entering the anterior chamber. The internal arm of the trabeculotome is introduced into the Slem's canal using external parallel arm as a guide. Once 80% of the trabeculotome is within the canal, it is rotated into the anterior chamber and the rotation is continued until 75% of the probe arm length has entered the chamber. In total, approximately 120 of the trabecular meshwork is ruptured by this technique. The trabeculotomy has been completed and now trabeculectomy part of the operation will be performed. The deeper block is excised to complete the trabeculectomy and iridectomy is then made. The scleral flap is then closed with one tenno nylon suture at the apex of the triangular scleral flap. The conjunctiva and the Tennant's capsule are then closed with a running suture of absorbable material using 8O vicryl suture. This is the appearance at the conclusion of surgery and 0.3 ml of dexamethasone injection is given subconjunctivally at the inferior fornix. Today we are seeing that the child's cornea is clearer than preoperative appearance, and by the end of 6 weeks the child will have totally clear cornea and fixation will develop and normal vision development will take place.
कल मेरे बच्चे का ऑपरेशन हो गया। कल डॉक्टर ने पहले बोला था बच्चे का ऑपरेशन करने के लिए थोड़ा सा रिस्क है। ऑपरेशन जब भी बच्चे का हो गया, डॉक्टर हकीम मेरे को खुद बोले कि ऑपरेशन सक्सेसफुल हो गया। हम दोनों इतने खुश हैं क्योंकि मेरा बच्चा देख रहा
और नॉर्मल लाइफ जिएगा, नॉर्मल, और
मेरा बच्चा नॉर्मल लाइफ जिएगा।
The child will be a perfect healthy human being with good vision, and I hope, I wish this child will become a doctor in future. Compare and contrast the preoperative and the 3 weeks postoperative appearance of the baby. At 6 weeks postoperative, the child had total clearance of corneal edema in both eyes and the bleb appearance was satisfactory. The child is enjoying age-appropriate normal visual acuity in both eyes, and the activity of the child is normal, and the parents are extremely happy with the surgical outcome. Primary combined trabeculotomy and trabeculectomy was very safe and effective in this premature infant with congenital glaucoma, and the child is enjoying age-appropriate normal vision.
दो साल पहले मेरे बच्चे का ऑपरेशन इसी अस्पताल में हमने किया था, जिसका नाम स्वर्णव है। आज वो 2 साल का हो गया है। ऑपरेशन इतना सक्सेसफुल रहेगा हमें उम्मीद नहीं थी, पर आज हमारा बच्चा हमारा कैसा सहारा बन रहा है आप भी देख सकते हो। कहीं पे भी मेरा बच्चा हमें हाथ पकड़ के लेके जाता है। ऐसा लगता है ये लकड़ी की जरूरत अभी 1 साल और रहेगी। 1 साल के बाद में अगर वो पूरा समझने लग जाएगा तो हमें ये लकड़ी की भी जरूरत नहीं रहेगी। हमारी लकड़ी हमारा बच्चा ही बन गया है। ऑपरेशन बहुत सक्सेसफुल रहा। आज हमारे बच्चे की हमको बहुत मदद होती है। घर में कोई बर्तन घूम जाता है तो बर्तन हमें ढूंढ के देता है। आज बच्चा देख सकता है तो हमें कितना खुशी होता होगा, आपको हम हमारी खुशी शब्दों में बयां नहीं कर पाएंगे। मैं मेरा पूरा परिवार एलवी प्रसाद अस्पताल का बहुत बहुत शुक्रगुजार हूँ, विशेषतः मंडल सर और उनकी पूरी टीम का बहुत बहुत शुक्रगुजार हूँ।
So what we have developed over a period of 3 decades is an integrated approach, integrating child's medical, surgical, genetic and rehabilitation approach. The improved surgical technique I was talking about will come to the end at the end of my presentation, an edited video of that. So here is a paper published a few years ago, 1128 eyes of 653 consecutive children done over a period of 21 years. Results were published, results are satisfactory. I am not going into the detail. Here is a paper published in 2023, 220 eyes of 121 patients done in the first decade, 1990 to 2000, and all the patients have at least 20 years of follow-up. The results are satisfactory. 46% of the patient gain normal vision, but that is 20/40 or better. A child who completed 27 years of follow-up here. And here is a child, the acute hydrops child, the photograph is here. The child is enjoying good vision with the spectacle correction for myopia. So this is a child who completed 30 years of follow-up. Now, in advanced cases where limbal distortion or distretching is so much, probably goniotomy is contraindicated. Barkan in his original publication said if the corneal diameter is more than 14, probably goniotomy can cause perforation of the globe unless it is done carefully. That's why we used to do combined trabeculotomy, trabeculectomy, avoiding mitomycin C but using implant.